Now, let's discuss the ligaments of the uterus. We have the peritoneal ligaments, which are not providing enough support to the uterus. This is the anterior ligament that consists of the utrovesical fold of the peritoneum, whereas the posterior ligament consists of the rectovaginal fold forming the rectovaginal pouch of the peritoneum. Now, the right and the left broad ligaments are fold of the peritoneum which attach the uterus to the lateral pelvic wall. When the bladder is full, this ligament has an anterior and the posterior surface and upper, lower, medial and lateral border. The upper border is free. The anterior and posterior layers of the peritoneum forms the ligament. The lateral and the inferior border of the ligament are attached to the corresponding part of the pelvic wall. The medial border is attached to the lateral margin of the uterus. The ovary is attached to the posterior layer of the broad ligament through the mesovarium. The ligament of the ovary passes from the lower pole of the ovary to the lateral angle of the uterus. The part of the broad ligament lying between the uterine tube and the ligament of the ovary is called the mesosalpinx, while the part below the ligament of the ovary is called the mesometrium. Now, the part of the broad ligament that is stretching from the upper pole of the ovary and the infundibulum of the uterine tube to the lateral pelvic wall is called the suspensory ligament of the ovary or the infundibulopelvic ligament. The broad ligament consists of the following structure. This is an important enumeration question. The uterine tubes, the round ligament of the uterus, the ligament of the ovary, the uterine vessels near the attachment to the uterus, the ovarian vessels in the infundibulopelvic ligament, the uterovaginal and the ovarian nerve plexus, the apopheron, the parapheron, some lymph nodes and lymph vessels, and dense connective tissue or the parametrium present on either sides of the uterus. Now, coming to the true or the fibromuscular ligaments, they are the round ligament of the uterus, the transverse cervical ligaments, and the uterosacral ligaments. Now, the arterial supply of the uterus, chiefly supplied by two uterine arteries, which are markedly enlarged during pregnancy, partly by the ovarian artery. The uterine artery is a branch of the anterior division of the internal iliac artery. It is first running medially towards the cervix, crossing the ureter, as you can see, it's the ureter, above the lateral fornix of the vagina and 2 centimeter lateral to the cervix. Then this artery ascends along the sides of the uterus with a tortuous course. Finally, it turns laterally towards the hilus of the ovary and ends by anastomosing with the ovarian artery, you can see over here. Now, the tortuosity of the artery permits the expansion of the uterus during pregnancy without stretching the artery. Apart from the uterus, this artery also gives branches to the vagina, the medial two-thirds of the uterine tube, the ovary, the ureter, and the structures present within the broad ligament. The venous drainage. The veins are forming a plexus along the lateral border of the uterus. This plexus drains through the uterine, the ovarian, and the vaginal veins into the internal iliac veins. You can see the veins over here. The lymphatic drainage. The lymphatics of the uterus begin in the three intercommunicating networks, one of endometrial, the other of myometrial, and then we have the subperitoneal. These plexus drain the lymphatics onto the sides of the uterus. Now, of these, the upper lymphatics from the fundus and the upper part of the body mainly drain into the aortic nodes and only partly to the superficial inguinal nodes along the round ligament of the uterus. The middle lymphatics form the lower part of the body and drain into the external iliac nodes. The lower lymphatics from the cervix drain into the internal iliac nodes and the sacral nodes. The nerve supply. The uterus is richly supplied by both sympathetic and parasympathetic nerves through the inferior hypogastric plexus and the ovarian plexus. The sympathetic nerves from T12 to L1 segments of spinal cord produce uterine contraction and vasoconstriction, whereas the parasympathetic nerves S2 to S4 produce uterine inhibition and vasodilatation. However, these effects are complicated by the pronounced effects of hormones on the genital tract. Pain sensation from the body of the uterus passes along the sympathetic nerves and from the cervix along the parasympathetic nerves. Now, the age and reproductive changes in fetal life, the cervix is larger than the body, which projects a little above the pelvic rim. At puberty, the uterus enlarges and descends to the adult position, and the arbor vitae uteri also appear. During menstruation, the uterus is slightly enlarged and becomes more vascular. The lips of the external os become swollen. As pregnancy advances, the uterine wall becomes progressively thinner. After parturition, the uterus gradually involutes and returns almost to the non pregnant size. In old age, the uterus becomes atrophic and smaller in size and more dense in texture. The internal os is frequently obliterated. The lips of the external os disappear and the os itself may be obliterated. Now, a very important topic is the support of the uterus. Okay. Now, uterus being a mobile organ undergoes extensive changes in size and shape during the entire reproductive period of life. It is supported and prevented from sagging down by a number of factors which are chiefly muscular and fibromuscular. Coming to the primary supports, we have the muscular or the active supports, which is your pelvic diaphragm, the perineal body, and the distal urethral sphincter mechanism. Then we have the fibromuscular or mechanical supports, that is the way the uterus has been placed, that is uterine axis, pubocervical ligaments, transverse cervical ligaments of Macondot, the uterosacral ligaments, and the round ligament of the uterus. These secondary supports are doubtful value and basically are formed by the peritoneal ligaments like the broad ligament, the vesico-uterine pouch fold and the fold of peritoneum, the rectovaginal or the recto-uterine pouch and fold of peritoneum. Now, role of individual supports. So let's come to the pelvic diaphragm. The pelvic diaphragm is basically supporting the pelvic viscera and resisting any rise in the intra-abdominal pressure. The pubococcygeus part of the levator ani is partly inserted into the perineal body here between the vagina and the rectum. Some of these fibers are also forming a supportive sling and a sphincter around the vagina. So, indirectly, for the uterus and the urinary bladder as well. Right? The pubococcygeus is torn. If it is torn during parturition, the support of the vagina is lost and the latter tends to sink into the vestibule along with the uterus, thus causing prolapse of the uterus. Now, the efficacy of the levator ani as a support is also lost when the perineal muscles are torn. They normally fix the perineal body over here and make it an anchor for the levator ani muscle. The perineal body, it is a fibromuscular node in which the 10 muscles are attached. It chiefly functions as an anchor for the pelvic diaphragm, thus maintaining the integrity of the pelvic floor. Now, the muscles are the two transverse superficial perineae, two transverse deep perineae, two pubococcygeus part of the levator ani, two bulbospongiosus, and single sphincter ani externus, and unstripped fibers of the longitudinal muscle cord of the anal canal. Now, urethral sphincter mechanism. The urogenital diaphragm does not exist as the sphincter urethrae is within the wall of the urethra. The sphincter urethral mechanism exists. In addition, we have the compressor urethrae and the sphincter uretrovaginalis. They are inserted into the vagina and they support the uterus indirectly. The uterine axis, the anteverted position of the uterus itself, prevents the organ from sagging down through the vagina. Any rise in the intra-abdominal pressure tends to push the uterus against the bladder and the pubic symphysis, further accentuates anteversion. The angle of anteversion is maintained by this uterosacral and the round ligament. Now, so what is the pubocervical ligament? It's the pubocervical ligament. It connects the cervix to the posterior wall of the pubis, right? This is the pubis and this is your cervix over here. Pubocervical ligament derived from the endopelvic fascia and corresponds to the medial and the lateral puboprostatic ligaments in the male. The transverse ligament, cervical ligament of Macondor, this is it. They have other names as well called the lateral cervical ligament, the cardinal ligament, paracervical ligaments, retinacular uterine substanticulum of Bonney. They are fan-shaped condensations of the endopelvic fascia on each side of the cervix, above the levator ani and around the uterine vessels. They are connecting the lateral aspect of the cervix to the upper vaginal wall to the lateral pelvic wall over here. About 2.5 centimeter ventral to the ischial spine, and they are forming a hammock to support the uterus. Okay, they are forming the hammock. The uterosacral ligaments, you can see over here, they are also condensations of the endopelvic fascia connecting the cervix to the periosteum of the sacrum at the level of S2 S3 and are enclosed within the recto-uterine folds of the peritoneum, which are forming the lateral boundaries of the recto-uterine pouch. The uterosacral ligaments keep the cervix braced backwards, you can see over here, against the forward pull of the round ligament. The two ligaments form a couple that maintains the uterine axis. The round ligament of uterus, this is the round ligament of uterus. They are two fibromuscular flat bands 10 to 12 centimeter long which lie between the two layers of the broad ligament antero-inferior to the uterine tube. This is the uterine tube. Each ligament begins at the lateral angle of the uterus, runs forward and laterally, passes through the deep inguinal ring, traverses the inguinal canal, and merges with the areolar tissue of the labium majus after breaking up into thin segments. In the inguinal canal, it is accompanied by a process of peritoneum during the fetal life. If it persists after birth, it is known in females as the canal of Nuke. The round ligament keeps the fundus pulled forward and maintains the angle of anteversion against the backward pull of the uterosacral ligaments. So that's all about the uterus. Thank you.